Hello and welcome to the topic Non-Hodgkin's lymphoma in the Haematology module. By the end of this topic, you should be able to define Non-Hodgkin's lymphoma, explain the pathophysiology and risk factors associated with Non-Hodgkin's lymphoma, outline the classification of Non-Hodgkin's lymphoma, describe the clinical manifestations and outline the investigations as well as the staging of Non-Hodgkin's lymphoma, and lastly discuss the principles of management of Non-Hodgkin's lymphoma. Let's get started. First, let's look at what lymphomas are. Lymphomas are simply malignancies of lymphocytes. Lymphomas are classified into either Hodgkin's lymphomas or non-Hodgkin's lymphomas. In this deck of slides, we will be exploring non-Hodgkin's lymphoma, which is a broad term including all types of lymphomas that do not have red Sternberg cells, which are characteristic of Hodgkin's lymphoma. The WHO subclassifies non-Hodgkin's lymphomas according to their degree of clinical aggressiveness and further by cell type. B-cell lymphomas are the most common subtypes of non-Hodgkin's lymphoma, comprising of roughly 85% of all non-Hodgkin's lymphoma cases. T-cell lymphomas only make up approximately 15% of cases. In this slide, we see the subclassification of clinically indolent non-Hodgkin's lymphoma. First, let's look at B-cell neoplasms. Small lymphocytic lymphoma and chronic lymphocytic leukemias are the same disease entity. In CLL, neoplastic cells are in the bone marrow and peripheral blood. In small lymphocytic leukemia or SLL, neoplastic cells are in the lymphatic tissues. Waldenstrom macroglobulinemia is associated with abnormal production of monoclonal IgM antibodies. Hairy cell leukemia is a mature B-cell neoplasm common in middle-aged men, commonly presenting with symptomatic pancytopenia and massive splenomegaly. Follicular lymphoma is the most common low-grade lymphoma in adults. Onset is insidious and painless, often with waxing and waning of lymphadenopathy and splenomegaly. Look out for translocation T14 and 18 at centrocytes, which are nodular small cells with cleaved nuclei. Next is marginal zone B-cell lymphomas, which are a group of lymphomas arising from post-germinal center B cells, most common in adults, and it is associated with autoimmune disorders such as Sjogren's syndrome and Hashimoto thyroiditis. There are three types of marginal zone lymphomas, which are extranodal, nodal, and splenic. Mycosis fungoides is the most common form of cutaneous T-cell lymphoma. There is only skin involvement that can manifest as pruritic cutaneous plugs and patches that develop brownish nodules and porphyrious microabscesses. Moving on to clinically aggressive non-Hodgkin's lymphoma, again let's start with the aggressive B-cell neoplasms. Diffuse large B-cell lymphoma or DLBCL is the most common aggressive non-Hodgkin's lymphoma in adults. Mutations found in this malignancy are BCL2, BCL6, and P53. A rare subtype known as primary CNS lymphoma is associated with Epstein-Barr virus infections and AIDS. Mantle cell lymphoma is most common in adult men. Disease often advances rapidly, and at time of presentation, patients are diagnosed with terminal disease. Burkitt lymphoma is the most common in children. In 75% of cases, there is a translocation of T8 and 14 that causes the overactivation of CMYC proto-oncogene, hence triggering transcription. There are various forms of Burkitt's lymphoma, where you have the sporadic kind, typically affecting the abdomen or pelvis, endemic, and this is associated with Epstein-Barr virus and most prevalent in Africa and South America. The disease affects primarily the maxillary and mandibular bones. Immunodeficiency associated, especially seen in HIV patients. Moving on to aggressive T-cell lymphomas. Adult T-cell lymphomas almost occurs exclusively in adults, and it's caused by human T-cell lymphotropic virus. Presentation is typically acute and leukemic. Hepatosplenomegaly, lymphadenopathy, cutaneous lesions are common. Upon initial investigation, there may be hypercalcemia that could manifest as abdominal pain, bone pain and psychosis, and elevated lactate dehydrogenase. Precursor T-cell lymphoblastic lymphoma predominantly affects adolescents and young adults, with males being disproportionately affected. Since this neoplasm originates in the thymus, a mediastinal mass could lead to dyspnea and superior vena cava syndrome. Moving on to the etiology and pathophysiology of non-Hodgkin's lymphoma. Though not definite, non-Hodgkin's lymphomas are associated with chromosomal translocations, infections, immunodeficiency, chronic inflammation, and environmental factors. Chromosomal translocations in non-Hodgkin's lymphomas play an important role in their pathogenesis and correlate with immunophenotypes. The most common chromosomal abnormality encountered is the T14 and 18 translocation, found in 85% of follicular lymphomas and 28% of higher-grade non-Hodgkin lymphomas. This translocation results in the mutation of the BCL2 apoptotic inhibitor oncogene. T11 and 14 associated with mantle cell lymphoma with overexpression of BCL1, a cell cycle regulator chromosome. T2 and 5 translocation found in the majority of anaplastic large cell lymphomas. T11 and 18 and T1 and 14 are associated with mucosal associated lymphoid tissue lymphomas or MALT. Several viruses have been associated with the pathogenesis of non-Hodgkin's lymphomas. Their ability to induce chronic antigenic stimulation and cytokine dysregulation may have contributed to this uncontrolled B or T cell proliferation. Examples of implicated virus include the Epstein-Barr virus, human immunodeficiency virus, human T-cell leukemia virus type 1, hepatitis C, Kaposi sarcoma-associated herpes virus. Not a virus but bacteria, Helicobacter pylori infection is also associated with primary gastrointestinal lymphomas in immunodeficient patients. Next would be immunodeficiency states such as severe combined immunodeficiency disease, SCID, and acquired immunodeficiency syndrome, AIDS, have been associated with an increased incidence of non-Hodgkin's lymphomas. Exposure to chemicals such as pesticides, herbicides, organic solvents, preservatives, and chemo or radiotherapy also have been linked to the development of non-Hodgkin's lymphomas, and that would be all the factors associated with non-Hodgkin's lymphoma. Patients with low-grade indolent non-Hodgkin's lymphomas are often asymptomatic and subclinical. On the other hand, aggressive disease may present with systemic symptoms, as listed here. Lymphadenopathy is not noticed by patients themselves, and either a CT or a PET scan is needed to discover the lesions. Listed here are the possible signs elicited in the office during a physical exam. Most patients, however, present with asymptomatic peripheral lymphadenopathy. Some have localized nodal involvement, though most have several groups affected at the same time of presentation. In some cases, enlarged mediastinal and retroperitoneal nodes produce pressure symptoms. The important ones are superior vena cava syndrome, due to the compression of the superior vena cava, manifests as shortness of breath and facial edema or plethora, jaundice due to compression of the biliary tree, hydronephrosis due to the compression of the ureters, vomiting and obstipation due to bowel obstruction, ankylous pleural or peritoneal fluid or lymphedema of lower extremities due to obstruction of lymphatic drainage. Next would be routine lab studies, which include full blood count, which may show anemia, thrombocytopenia, and variable white cell count. Serum calcium is raised, lactate dehydrogenase is usually elevated, beta-2 microglobulin may be elevated, and this generally confers a poorer prognosis. And there may be abnormal liver function test results, and this could be secondary to hepatic infiltration, and blood smears may reveal immature nucleated red blood cells with white blood cell precursors, abnormal lymphocytes, and circulating blasts. Viral serologies may be used to investigate possible underlying causes, and this includes HIV, hepatitis B virus, hepatitis C virus, Epstein-Barr virus, and HDLV virus 1. Confirmation of non-Hodgkin's lymphoma would require histopathology studies, most often lymph node biopsies, and sometimes bone marrow aspiration and biopsy. In nodal disease, the most appropriate node for biopsy would be one with significant progressive and persistent enlargement. Flow cytometry and immunohistochemistry are used to establish the type of lymphoma based on surface markers. Flow cytometry is especially useful when malignant cells are suspended in pleural effusion. Possible findings are CD20 positive in B-cell lymphomas and CD3 positive T-cell lymphomas. Cytogenetic studies with fluorescence in situ hybridization of fish is useful in confirming the diagnosis and prognosis. T14 and 18 translocation in follicular lymphoma, T11 and 14 in mantle cell lymphoma, T8 and 14 in Burkitt lymphoma, and CMYC translocations predict an aggressive behavior of DLBCL and transformed follicular lymphoma. PCR may be used to detect tumor markers such as BCL1 and BCL2, and are especially useful in cases where very small amounts of samples are available. Other tests include lumbar puncture in cases of Burkitt lymphoma where there is primary CNS lymphoma or AIDS-related B-cell lymphoma, or any lymphoma with neurological signs and symptoms. A colonoscopy can be done in cases of marginal and mantle cell lymphomas. Here you may see micropolyps. An echocardiogram or multiple gated acquisition scan, MUGA scan, can be done to establish baseline function prior to chemotherapy as well as in monitoring potential cardiotoxicity. Chest X-ray identifies hilar or mediastinal adenopathy. A CT scan is useful for not only initial staging but also assessing treatment response and follow-up. And finally, a fluorodeoxyglucose positron emittent tomography or FDG-PET scan or a CT scan is the gold standard for staging and evaluation of post-treatment in patients with aggressive DLBCL and follicular lymphomas. Ann Arbor is most commonly used for staging patients with non-Hodgkin's lymphoma, divided into 4 stages. In stage 1, only a single lymph node region is affected. If there is localized involvement, a single extranodal site is staged as 1E. In stage 2, 2 or more lymph node regions on the same side of the diaphragm are involved. In stage 3, lymph node regions on both sides of the diaphragm are involved. Stage 4, it is the disseminated disease or multifocal involvement of more than one extra lymphatic sites with or without associated lymph node involvement or isolated extra lymphatic organ involvement with distal nodal involvement. Patients can also be categorized in A or B designation. Patients with A disease do not have systemic symptoms, whereas those with B disease or B symptoms may have unexplained weight loss, more than 10% of their body weight in 6 months before diagnosis, unexplained fever above 38 degrees Celsius, and night sweats. Most patients diagnosed with non-Hodgkin's lymphomas will require chemotherapy, radiotherapy, or both. Indolent cases may warrant a watch and wait strategy. Specific regimen are selected based on the subtypes, staging, and prognosis. In general, low-grade lymphomas at initial stage, radiotherapy is done with curative intent. In low-grade lymphomas at its advanced stages, treatment is palliative in nature. High-grade lymphomas warrant chemotherapy with curative intent. Additional interventions include splenectomy and stem cell transplants. Systemic chemotherapy comprises of chemotherapeutic agents, steroids, immunotherapy. CHOP is the most common regimen in non-Hodgkin's lymphoma. The addition of rituximab R, a CD20 antibody, is done for B-cell lymphomas. Intrathecal chemotherapy with methotrexate can be used in leptomeningeal involvement. Patients undergoing chemotherapy should be given prophylactic granulocyte-stimulating colony factor or GCSF to prevent neutropenic fevers. In patients who have severe neutropenia, consider administering prophylactic antibiotics alongside chemotherapy.
Patients on high-dose cyclophosphamide or ifosfamide should also receive Mesna, a chemoprotectant to prevent hemorrhagic cystitis. For patients with high risk of CNS relapse, CNS prophylaxis with intrathecal methotrexate or cytarabine should be part of treatment. Patients with persistent DLBCL despite first-line therapies may be considered to be candidates of chimeric antigen receptor. These are T cells that have been engineered to recognize tumor antigen. And lastly, splenectomy should be considered in select patients with splenic involvement. This is a picture of an excised spleen with massive involvement in the form of multiple nodules, some of which coalesce. Generally speaking, the prognosis of this lymphoma is worse than Hodgkin's lymphoma. Median survival of low-grade lymphomas are 6 to 10 years. High-grade typically only survive a few months. Indicators of poor prognosis include old age, number of sites involved, elevated LDH, increased beta-2 microglobulin. The International Prognostic Index utilizes clinical features that independently predict survival. Follicular lymphoma is the second most common subtype and has its independent prognostic index. It appears to be more discriminating than the International Prognostic Index and is calculated based on adverse prognostic factors. So let's summarize. Non-Hodgkin's lymphomas comprise of all lymphoid malignancies that do not fit into Hodgkin's lymphoma that have characteristic Reed-Steinberg cells. Non-Hodgkin's lymphomas are classified according to clinical behavior and cell types such as B cells, T cells, and K cells. Low-grade lymphomas originate from mature cells with a slow growth rate and have an indolent clinical course. High-grade lymphomas grow rapidly and are aggressive in nature. Diagnosis is based on histopathological examination of affected tissue as well as immunophenotyping and molecular studies which allow identification of specific subtypes. Treatment vary between each subtypes of NHL, but generally they comprise of chemotherapy and radiation. The most common regimen used is CHOP, C for cyclophosphamide, H for hydroxydaunorubicin, O for oncovin, and P for prednisolone, R for rituximab, which is added to the CD20 positive disease. Prognosis of this type of lymphoma is worse than of Hodgkin's lymphoma. We have come to the end of this session. Thank you.